The spine, as you know, is a fairly complicated system, and too many people make it into something that's very simplified. You know, it's this rod of bone that basically everything, revolves around. And as many of you in the crowd know, and by the way, my wife's an occupational therapist, so I have a special place in my heart for the therapy world, and taught PTs for about 2 decades. So great group. So we'll go through, we'll look at the back, the spine, however you want to define that, and go through first, look at some of the osteological features, remind you of some of those that are of importance. Then we'll add on top of that some ligaments that bind all of those structures together. We'll start at the top and move down, and then we'll add muscles, and then at the very end, we'll just add to the mix, we'll throw in some nerves and vessels. So when you look at the spine articulated like this, you see an anterior and a posterior view on this image. And the first striking thing is that the anterior part of the spine from top to bottom, from C1 all the way down to the coccyx, is nice and smooth, right, in most people. And that nice and smooth nature lends itself to being faced inwardly, where you have very delicate viscera. Right, so those visceral structures, intestines, heart, lungs, running up and down all day, moving over a roughened spine would not do well, right? So everything on the inside has a nice smooth structure, assuming you don't have osteophytes, etc. The posterior aspect and lateral parts of the spine are roughened, right? Lots of protuberances, bony excrescences, etc. And these are for the attachment of tendons and ligaments. So you'll take the spine, and if you look at what makes up the spine, there's basically bone and intervertebral disc, right? And those intervertebral discs, if you were to remove them, that would take you back to the primitive design of the spine, which is when you're in utero and have a nice C-shaped spine, right? These are called your primary curves. So these were there in the very beginning, and are due to primarily the lack of intervertebral disc material, which gives you those curvatures, in addition to when you start to hold the head up, right, for your cervical reversed curve, and when you start to walk for your reversed secondary lumbosacral curve. So you can look and see at the cervical spine that we reverse that curvature once the baby starts to hold the head up, right? So you get that reversed secondary curve. The thoracic spine maintains its embryologic curvature, and if anything, accentuates over time and becomes more pronounced as you lose both vertebral body height and intervertebral disc height. The lumbosacral region reverses its curve, and that occurs after you start to ambulate. You all know, so there are 7 cervical vertebrae, 12 thoracic, 5 lumbar, a sacrum, which is fused 1 to 5 vertebral segments, and a coccyx that's 2 to 4 to 5 little segments, depending how much of a remnant of a tail that you have. So kind of take-home messages when you're thinking about those curvatures is that in the cervical region, the intervertebral discs are taller anteriorly, so that helps to develop that secondary curvature, especially with the nuchal muscles beginning to take play as you start to hold the head up and hold the curvature in a reverse nature. The lumbar intervertebral disc and bodies are taller anteriorly, so that helps with that secondary curvature that you see more inferiorly. So kind of a distilled version of what's happening is that the primary curvature is due to the vertebral elements themselves, and the intervertebral disc help form the secondary curvatures. Embryology is usually a sticking point for most people, so this is 2 slides of every single piece of embryology you need to know about what makes the spine. So we have gastrulation, which has formed us into 3 different layers. Endoderm that helps form the internal organs, a mesoderm that helps form things such as bone and muscle, and an ectoderm that forms your skin and then progresses to help form the nervous system. On day 20 of gestation, you have blocks of mesoderm, which we call somites. And as you can see here, these are roughly equivalent to the parts of the spine that they're going to form. Each of those blocks of somites then divide into 3 different things, right? One will divide into a sclerotome, and all that means is a certain area of bone that's from that block of somite. Some will develop into a dermatome, which is an overlying piece of skin from that somite, and then some will develop into a myotome, which is a muscle associated with that bone. So very easy, 3 things from each somite. If we move on down, the notochord is a column of specialized mesoderm that helps influence the overlying ectoderm and basically induces it to not turn all into skin, but for some of it to turn into your nervous system. So a very important step in the developing part of the spine. One thing to notice on the far right picture is that if you look at the spinal cord that's inside the spine, right, in the very beginning, and we have the little blocks of vertebrae, and you see that there's a nerve segment that's almost horizontal, perpendicular to that bone as it runs down, and that's the way you are in utero. So each block has a nerve, et cetera, et cetera. And then what we'll see is that as the vertebral column starts to grow faster than that neural tissue on the inside, it takes over and loses the spinal cord in the dust. So that your spinal cord only fills the spinal canal down to around L1 in most people, and then everything below that is just nervous tissue that we'll see as we go through. So we start off segmentally innervated, right, is the point. And then as we start to move and have various changes in the anatomy, then we start to see that the nerves have to do different things. We'll skip these. So let's get to some meat of the matter. So cervical vertebrae. So the cervical vertebrae are the smallest of the vertebrae that you see in the spine, and there are 7 of them. And we'll see in a few minutes that there are 8 cervical nerves. So we have to fit 8 cervical nerves between 7 cervical vertebrae, and we'll see how that happens. Some of the essential things to remember about the cervical vertebrae, and this is more true of vertebrae 3 through 7. 1 and 2, the atlas and the axis, have such a variant anatomy that we'll describe those individually. But if you look at the AP diameter of the cervical canal, right? So the space that's here, right? It tends to be very large. Some of the largest vertebral canals are in the neck, right? Now, why do you think that is? Why is that canal bigger in the neck than it is in the thorax, for example? Because what's in there is bigger, right? And what's in there is the spinal cord. So why would your cervical spinal cord be bigger than your thoracic spinal cord? And it all has to do with what it's going to innervate. So if you have a lot of muscles to innervate in an area, the cord will be bigger, hence the spinal canal is bigger. And the thing that the cervical spinal cord is innervating, more or less, is your upper limb, right? So wherever you have a limb, you're going to have a bigger spinal cord, more nerves. And you see the same thing in the lumbosacral region. So where the lumbosacral plexus arises, you have a larger part of the spinal cord. Thoracic region, the only thing that the thoracic spinal cord has to innervate would be intercostal muscles and some skin around the thorax. So the bottom line is that the vertebral foramen or canal is going to change depending where you are. Uncinate processes. So these are little hook-like structures. We don't see them as well in an superior view, but they're here on the lateral part of the bodies. And in the upcoming slide, I'll show you these things help to wedge the vertebral column together in the cervical region. They keep the slippage of the vertebral bones from happening, especially since you have to trade off high mobility in the cervical spine, but you have to do something to keep it from disrupting, subluxing, and injuring the underlying spinal cord. So uncinate processes are important, and you see these on the cervical vertebrae, even including down to T1, and we'll see how those interlock into place. The other thing you see when you look at the cervical vertebrae, the variant, is that in the transverse processes, you have these vertebral foramina, and that's for the important vertebral artery, which runs through all of these cervical transverse processes, except for usually C7. So he's usually spared, but still has the foramen. Vertebral arteries we see later on is very important. It's not just something to look at and go about your way, because left and right sides supply 1/3 of the blood to your brain. So cervical manipulation that may injure one of those vertebral arteries can have a significant consequence. You also note the facet joints are in the transverse plane, and you can look at the difference between the superior articular facets and the inferior articular facets. And as I show you some additional views, you'll see how these interplay with each other. And again, the whole idea is to have increased mobility about these facet joints, or to be more proper, zygapophyseal joints, and at the same time have stability. So there's a back and forth between those two. Just to show you the relationship of the different vertebrae. So in the cervical region, you can see kind of the slanting facet joint here. In the thoracic region, there's more of a shingled appearance between the superior and inferior facets. And then in the lumbar region, you almost come to a coronal section where there's a locking mechanism between the facet joints that increases the stability of the lumbar region and doesn't let it move as much as you can in the cervical region. In the thorax, the mobility of the facet joints is limited by the rib cage, right? So your rib cage is basically a big bandage or a brace that keeps you from having hypermobility there. Also, when we look at the differences here, you'll see that the intervertebral foramen, right, here and here, where our intervertebral nerves or our spinal nerves are going to come out. Here in the cervical region, there's a lot of bone associated with that, and there's a little piece on the transverse process, the sulcus, that allows the nerve to move. In the thorax, it's a little bigger area. Lumbar region, it's extremely large. And typically, as you move down the spinal column, you'll see that the nerves get a little larger. So the femoral nerve, for example, is a lot larger than some of the nerves off the cervical plexus. So the key is when you have stability of the spine, right? This is the odontoid process, C2, 3, 4, 5. We're trying to protect this fellow here, the spinal cord. So we have to have lots of mobility, and the spinal cord will move in this canal, but it doesn't have a lot of space for movement. So if anything impinges and provides a mass effect there, so a disc, a ligamentum flavum that's hypertrophied, an osteophyte, etc., then that can cause problems and has to either be decompressed or it can injure the nerve underneath. So we're going to start off and look at some of the changes that biology has afforded to the cranial-cervical junction. And what it's done is it's specialized the first and second cervical vertebra, and it's done that so that there's increased motion, but at the same time, by increasing the motion at those two levels, you have to have a specialized set of ligaments that help hold everything together, and you don't see those ligaments in other places of the spine. So this is the C1 anterior arch. These are the occipital condyles, inferior arch, and then the transverse processes. And the transverse processes of the C1 vertebra are the longest in this area, and if you find the angle of your mandible and then palpate just deep and behind that angle of mandible, you can feel a little knot there, and that's the transverse process of C1. So one thing that came about is that biology devised this pivot so that in humans it allows us to move the head side to side and allows us to move the head up and down. If you look at some animals that can't do that, like a crocodile, if you hold a crocodile's head, what happens to the body? Right? It moves with the head. You can't move the head so independent of the body. And that's because they don't have this represented in their anatomy. It's quite different. So the C2 vertebra, right, has this protuberance called the odontoid process, or the dens, and it articulates up inside C1's vertebral foramen. But because we've got spinal cord here, it has to be really closely guarded here so it doesn't move back. So there's special ligaments here, and we'll see that a little bit down the road. But one in particular that sits just here is called the transverse ligament, and that's kind of the seat belt that keeps the odontoid snug anteriorly and creates a joint there, an anterior median atlantodental joint. We also have a little joint behind, and then the facet joints that are lateral. The occipital condyles would sit here, and then we see the posterior arch of C1. So C2 to C7 have a spinous process, right? C1 just has a posterior arch. There's no spinous process. There's no lamina. It's just this arch-like structure. This is C1 from above, and you can see the posterior arch we just talked about has a capacious vertebral canal. And then the anterior third is where we see the odontoid. So he sits here. And then between these atlantal tubercles, there's that strong transverse ligament. So this anterior third has to stay guarded from the posterior two-thirds. Here are the superior articular facets, right? And they often will have this bilobed nature for the condyles to rock back and forth, kind of like an egg in a spoon, right? That moves back and forth. That's just like the occipital condyle articulation with the C1 superior articular facet. This is what you just touched, the transverse process tip. And if you could push a little harder through the bone, you could feel the pulse of the vertebral artery, right? So vertebral artery is not far away from that angle of the mandible that I just showed you. Here's an anterior arch of C1 and anterior tubercle, posterior tubercle for muscle attachments. Interestingly, when you fracture C1, because it's a circular bone, you always have two sites of fracture. So when you look, you'll never see a fractured C1 that's just here. It's going to have here and here, because when you break a circle, it'll break in two places. This is another view. This is one of our specimens from the lab. You'll also see a little facet, right, a little concavity here just behind the anterior arch, and that's for C2's odontoid process to articulate. You also note lots of little vascular foramina. People think of bone as being this piece of concrete that has no way of, getting good blood supply. The bones have a huge reservoir of blood inside of them. This is one example of remembering that the anterior arch, this is in a child, and was sent to a clinic, and they thought the child had a fractured anterior arch of C1, and that's normal. That's just a normal developmental phase of that. So everything in between these pieces would be full of cartilage. So that's just a young C1, including here posterior arch. What do you think that is? The dens, right? The odontoid. Just a flavor, a few variants that you'll see pretty commonly. Normally the vertebral artery, after it comes up through the transverse foramen, it then curves right behind the superior articular facet. So this is superior articular facet, posterior arch, anterior arch, in this groove for the vertebral artery, and then it ascends and goes up inside the cranium, right? And normally has a little bit of give here. So when you move the head sideways, and there's a little translation that occurs at the occiput C1 joint, that artery has to move with it. Occasionally, you'll see some bony anomalies, like this little arch of bone, a posterior ponticulus, and it forms a little accessory foramen called the arcuate foramen. So the vertebral artery would come through here before it finishes running through the vertebral groove, and that can be a point where the artery can be compressed or tethered so that when you move the head, especially with chiropractic manipulation, if you have a tethered artery and you pull on it, you can avulse the artery. You can also have things of this nature. So some people will try to palpate the posterior arch of C1, which you can usually do if you hyperflex the patient and if they don't have too much fat on the back of the neck. But you'll feel the posterior arch, and occasionally you can't because it's pushed forward and it's fused to the occipital bone. So this is called atlanto-occipital assimilation or fusion. And these patients will have some limited motion at that joint, obviously, because it's fused. And what that usually results in is they have hyper movement below that. So the C2, C3 joint will become more arthritic quicker because it's moving more due to the fusion above. So odontoid process, you'll notice on C2 that the superior facets have this slanted appearance, right? In the midline, there's a little median crest. Here we see the inferior articular facets, and then the transverse process, which comparing to C1, where the transverse processes are almost horizontal, the transverse processes of C2 have this downward angulation. This is a cut that goes right through the C2 body. So this is the posterior arch. This is the odontoid. And you can see it's packed full. It's not a solid piece of steel or bone. It's packed full of trabeculae. So these trabeculae will be full of blood and has a little area so that the odontoid doesn't start off being a solid structure. It has multiple little pieces that fuse together, and that structure at the tip of the pin is a remnant in an adult of the synchondrosis, the cartilaginous joint that used to be there, and can cause problems because it's a weakened area, and that's one area where you can have odontoid fractures is through that weakened synchondrosis. You can have fusion of the cervical vertebrae, referred to as Klippel-Feil anomaly. So this is C2 and 3 fused on the left. You can have a posterior arch that's not fused, anterior arch, anything you can think of you can have. If we look at the cervical vertebrae articulated and from the side, you see this nice little sulcus for the spinal nerve. We see the vertebral foramen here. Here's the slanted zygapophyseal joint. And you also note that many people, the spinous processes of C2 down to C6 are often bifid, right? They're split, so you'll feel two little parts, and that's more common in Caucasians. From the front, this is a beautiful representation of the uncinate processes and how these are articulated together. So these little edges of the body of the cervical vertebrae are the uncinate processes, and they help to lock those bones in together. You'll also see that just behind that uncinate process is where the spinal nerve is coming out. So one surgical approach for a compressed stenotic intervertebral foramen in the cervical region is to do an anterior approach and to drill out one of these uncinate processes. You can see those here as well. There's a lot of debate in the literature whether these uncinate processes in their joint is a true joint and actually has synovium and synovial fluid, but we'll leave it at it's controversial. Posterior aspect of the cervical vertebrae, we see C1 on top, the Atlas. Remember in Greek mythology, Atlas was the guy that held the world on his shoulders, so that's the derivation of that. We see the dens or the tooth-like appearance here, and then we see the bifid spinous processes all the way down to C7, which doesn't have that bifid nature, but has a single, very pronounced spinous process. And because it's so pronounced, and you can usually feel that very easily at the upper part of the thoracocervical junction, it gives the name to the entire vertebra as the vertebra prominens, or the prominent vertebra. As we look in the thoracic spine, some changes that you see, you'll note that the spinous processes start to angle down and almost shingle on top of each other as you're going from superior to inferior. The vertebral foramina have a circular shape, right, and a more less area here for the spinal cord. The transverse processes, you'll note that they have little facets on the edges, and those little facets are to articulate with the ribs that you find in the thoracic region. And you'll actually see two little facets on each thoracic vertebra, two that are for the same rib. So one that's here back closer to the body, one that's on the transverse process, and then you'll see another half facet that's for the rib below. So he'll articulate here and here. You see the formation of the intervertebral foramen, which is formed by our intervertebral notch, right, here and here. And not shown here, and also contributing to that intervertebral foramen is the intervertebral disc, right, which we want to stay where it's supposed to be and not move into that intervertebral foramen. That's where most stenotic changes that affect the spinal nerves occur. So 12 thoracic vertebrae, the very first tends to look kind of like a cervical vertebrae, right? It's kind of a watershed area. And then 12 starts to look very similar to some of your lumbar vertebrae. So they don't just have a completely different design. They fade in and fade out. You also see that the bodies of the thoracic vertebrae have a heart-shaped, right? Valentine's Day yesterday, so appropriate. Little heart-shaped structure. If we look at a lateral view, we talked about the circular canal, the shingled superior facets, right, that we see here. The facets are almost in the coronal plane, right? So just like this, and if you have that coronal plane, that allows for a little bit of increased mobility. And the way that you seatbelt that mobility and control it is by having the rib cage attached. So the rib cage will keep those segments from being too hypermobile. The 2 points of articulation with the ribs, right? So here's our vertebral canal, which is about 15 millimeters in the thorax, bigger in the cervical and lumbar regions. Here's our proximal rib attachment onto the body, and there's the other rib attachment onto the transverse process. Posterior view, and we see those same facets. You can see really on this how the spinous process is really angled inferiorly. The inferior articular facets kind of tucked up underneath and difficult to see from an anterior view. And then we see the superior articular facets that extend up more than below. Some oddities that you can have. This is a hemivertebra. If you see someone with scoliosis, you have to think hemivertebra as they're one of those lying around causing this to tip over, and this happens to be a hemivertebra of the T3 vertebral body. Now we get down to the more robust lumbar vertebrae. So from the side, you'll see the hatchet-shaped spinous process of the lumbar vertebra. We see a very large surface area on the facet joints, inferior and superior. Very large transverse processes, a very stout, square-shaped vertebral body, enlarged compared to the thorax spinal canal. A couple of bumps and tubercles that you have in the lumbar vertebrae that you don't have in other spaces. One is called the mammillary process, which is here right at the superior articular facet. There's our transverse process. And then here kind of in the angle of the L shape, we have an accessory process. The mammillary process is for the attachment of your multifidus muscles in this area. The accessory process is for attachment of your longissimus muscle in this area. Between those of adjacent vertebrae, so between accessory mammillary processes of a vertebra above and below, you have an important ligament called the mammallo-accessory ligament, and it's the medial branches of the dorsal rami that travel in through underneath that ligament. And you can have ossification of the ligament that compresses it. Interestingly, that branch goes to the multifidus muscle, but more importantly, especially for the interventional people, is that those medial branches of the dorsal rami innervate the joints. They innervate the facet joints and may have some additional contribution to the intervertebral disc innervation, which we'll get to shortly. You can have, there's an area, and this shows it nicely, on the, especially the lumbar vertebrae that sits at the base of the lamina, which is here, and the superior articular facet, and that's called the pars interarticularis, and that's the area that can have fracture or weakened area, controversial whether it's congenital or acquired or maybe some of both. But when that happens, through the pars articulation, you can have movement of this posterior part of the vertebra posteriorly, and that initial phase is just a lysis, and then everything that moves forward is going to be a translational effect of the vertebra. Lumbar vertebra, you can see the nature of the hatchet-shaped spinous processes. You can note that the facet joints are turned and they're almost facing one another side to side. Very robust transverse processes. Interestingly, if you look kind of at a posterior view of L1 to L5, L1 and 2 have a flower pot appearance if you connect the dots between their facets, top and bottom. And then as you move down 3, 4, and 5, you get more of a square or rectangular shape. And that's due to the amount of weight that's coming down. So those vertebrae have to be more stout to support greater weight that's being pushed on them. The sacrum, anterior and posterior views of the sacrum. The sacrum, its whole coming to life is to essentially act as a transducer, to take all this heavy weight coming down the spine, transduce it out across the iliac crest, and then down into the femur. And it's designed to be somewhat of a wedge. That's why it's diminutive as you start to go down toward the tip of the sacrum and wider up top near the ala. The sacrum, the name sacrum, sacred, something that's sacrosanct, is supposedly the bone that the ancients thought didn't degenerate when you died and you would be brought back to life from the remnants of your sacrum. So an interesting derivation. Also, we see on the anterior sacrum, it's nice and concave. It's more concave in females than males so that you can accommodate a fetal head. The sacral promontory will be a little less robust in females for that same reason. The ala will help form this anterior articulation over with the ilium. We see the first sacral vertebra. So remember, these are 5 vertebrae that are fused together. And this very highest one will articulate with the L5 vertebra below. And you can look at the spinous processes of these fused vertebrae that form this median sacral crest that you can palpate on, gracile people. We see these posterior sacral foramina that will allow the dorsal rami that come out to innervate muscles and skin here. We see that anteriorly, we have anterior sacral foramina for the ventral rami of those same structures. Coccyx, little rudimentary bone that articulates here just below where we have our sacral hiatus, where if you want to introduce epidural anesthesia with a caudal block, this is where the needle is placed up inside this canal and then bathes the extradural space because the dural space ends at S2. So if we open this, we would see the caudal end of the dural sac here. This is a great representation that shows the articulation, like pages of a book, of the ilium for the sacroiliac joint. And we see that there's this roughened area that's posteriorly located, and that articulates with this tuberosity segment of the sacrum. And then more anteriorly, an articular surface, and we see the articular surface here on the corresponding ilium. So if you fold that page over, you can see nicely how those go together. The sacroiliac joint, most joints are either cartilaginous, synovial, fibrous, they're one or the other. The SI joint is two, so it has components that are both synovial and components that make it a syndesmosis, so it has somewhat of a fibrotic portion. The SI joint has some mobility. The ligaments of the SI joint will become lax with pregnancy, so oxytocin makes them lax so that the sacrum can be pushed posteriorly to allow the extrusion of the fetal head. The SI joint starts to fuse around 50, so Andy and I are starting to become concrete here with fusion of the SI joint, which is not all bad. And we'll talk about the innervation, a special innervation, controversial innervation of the SI joint as we move along. So here's a nice axial section that's interesting. So we see the pelvis here, the ilium, here's the sacrum on cross-section, and we see these strong ligaments, these interosseous ligaments of the sacrum that help bind it to the ilium. Here's the actual joint space, sacroiliac joint space. Here's the sacrum. And a couple of ligaments that help to kind of keep everything in check, especially with weight being distributed from top down. One is the sacrotuberous ligament that we'll go into more detail with here shortly, obviously from the sacrum to the ischial tuberosity. The sacrospinous from the sacrum to the spine, and these help, again, bind and keep the sacrum from moving too much. We'll also see later on that between those two ligaments is a delicate little nerve that comes out of the greater sciatic foramen, runs between the nerves, and then runs out through the lesser sciatic foramen, and that's the pudendal nerve. So pudendal nerve blocks at end-stage pregnancy where maybe the mother didn't want an epidural, but now she's starting to have pain and doesn't want to have to endure the pain with an episiotomy, etc. A pudendal nerve block can be done transvaginally where the physician places the finger up, palpates the ischial spine, thus palpating the sacrospinous ligament, and injects anesthesia into this area to numb the entire pudendal nerve and its wide distribution to the skin of the perineum and associated muscles. This is a great bird's eye view of the sacrum. We see the large ala, the wings of the sacrum. We see the sacral promontory, superior articular facets, sacral canal, and our median sacral crest. You also see here that the intervertebral foramen of the sacrum is inside the bone, and then it has an exit through these posterior sacral foramina, anterior sacral foramina. So posteriorly, our dorsal rami will exit, and we'll go over what those are, and the nerves. Ventrally, we have our ventral rami, which contribute primarily to our sacral plexus for S2, 3, and 4. You can have oddities of this area of the spine. Some common things would be supernumerary vertebrae. So you have an extra thoracic or an extra lumbar, or you have less than the number of lumbar thoracic that you normally have. Lumbarization, sacralization can happen up to 10% for the lumbarization. Gorilla ribs, anyone heard of that before, where you have a rib associated with one of your lumbar vertebrae. Those happen more rarely, but we see them occasionally. And the transverse process of the lumbar rib, the lumbar vertebrae, is essentially a rib, so elongation of that transverse process. This is a specimen from our lab that shows some nice features with a little artificial intervertebral disc here, but there's the promontory, our anterior sacral foramina. You can also note here on this, here's the transverse process of L5 and the ala, and with different anatomies and aging, those two start to come closer together. And the problem is that the nerve that's exiting here is the L5 nerve. So one cause of extra canal stenosis of the L5 nerve is here in this area that's referred to as the lumbosacral canal. Okay, so that's kind of a global view of some of the main bone structures. Let's start to fuse those bone structures together with some various ligaments. And everyone's familiar with the intervertebral disc that sits between the two vertebral bodies above and below. We also know about the cartilaginous end plate, which is a hyaline cartilage. There's been some debate as whether the end plates are actually part of the vertebral body or actually part of the intervertebral disc, and we will not get into that. In this cross-section, you can see the outer annulus fibrosus, which is mostly collagen, and then the inner nucleus pulposus. Nucleus pulposus that we would see here is mostly water, polysaccharides. The annulus is just basically fibrocartilage, and there's about 10 to 20 concentric rings that run around forming this annulus. And if you look at it from this view, these concentric rings are in overlapping angulations at about 65 degrees. So 65 degrees one way, 65 degrees the other way, front, back. And that interlacing helps to structurally support the disc. However, there's usually a weakened area that's described on the posterior lateral surface of this ring. And believe it or not, right, that's where most of your disc herniations occur of the nucleus pulposus, is through that weakened area. The height of the vertebral column, we kind of touched on this initially, is about a fourth due to the vertebral disc. So if we took all our vertebral disc away, you'd be a fourth shorter. There's compression of the intervertebral disc, so at night when you lie down, you're taller, right? When you stand up, you're going to be a little shorter. That may be hard to measure, but it happens. Anterior longitudinal ligament, extremely important ligament for the spine, and runs from the base of the skull all the way down to the sacrum. It is a wide ligament. There's intercrossing fibers here on the front of the vertebral bodies. There's a few elastic fibers, but it's mostly collagenous. There's a superficial layer of that ALL that spans up to 5 segments at a time, and then a shorter, deep segmental. And as you pull the anterior longitudinal ligament forward, you'll see that it has a very strong attachment onto the disc, even more so than it does the body. And intuitively, if you looked at the placement of the anterior longitudinal ligament, you'd see that it prevents or restricts hyperextension, right, by keeping those vertebral bodies in alignment. Next. This shows you nicely the posterior longitudinal ligament here running on the anterior surface of the vertebral body, and then behind that a segmental ligament binding the lamina above to below is your ligamentum flavum. Here we see a little bit of ligamentum flavum, and the thing to note is that the ligamentum flavum is forming part of this intervertebral foramen. So hypertrophy of the ligamentum flavum, buckling of the ligamentum flavum, all those come into play and help to form stenosis of that important intervertebral foramen. You can see the nerve roots exiting through their dural sheath and through the intervertebral foramen. The ligamentum flavum has a lot of elastic tissue in it, and the idea is that when it restricts motion and brings it back to a neutral position, that it doesn't buckle inside the spinal canal and cause impingement of the neural structures. This nicely shows a little bit of herniation of the nucleus pulposus into the bone above and below, and those are referred to as Schmorl bodies, and those are normal findings on imaging. A beautiful view of the yellow ligament, right, which is the ligamentum flavum, that has superficial and deeper parts, but runs basically between a vertebra above and below. And then we see laterally it has some connection with the capsule for the facet joint. So there's some connections between the two. Some other type of ligaments in the thorax, we see a thickened ligament that helps bind the head of the rib to the vertebral bodies. That's called the radiate ligament. There's a little interarticular ligament that holds the apex of that rib to the intervertebral body. We also see some superior costotransverse ligaments. Those are important because dorsally, as we start to move around and look at some of the back muscles, you'll see that the dorsal rami run basically between those superior costotransverse ligaments. Like we saw in the lumbar region where you have the mammalo-accessory ligament for that medial dorsal ligament, here we see that it's a different structure. Then you have occasionally these transforaminal ligaments that people don't talk about. So these run in different areas. They're near or within the intervertebral foramen and can potentially cause impingement of the spinal nerve as it's exiting through its intervertebral foramen. So this is a collage of some of the various transforaminal ligaments. This lumbar vertebrae, so we've opened down. We know this in the lumbar region. We see cauda equina, this is the dural sac, and then nicely we see the opened facet joint. So this capsular ligament, which is a thickening of the facet joint externally, will have synovium within it, also has little pieces of fat that are there and can egress in and out of the facet joint depending on the pressures involved. We have an anterior view of the posterior ligamentum flavum here. Usually a little gap between the two ligamentum flava, and that gap is what you would ideally like to go through when you're doing a lumbar puncture. Here's the anterior longitudinal ligament, capsular ligaments. We even have some intertransverse ligaments that help stabilize this area. In the thoracic region, there's a lumbocostal ligament. There's even a syndrome, lumbocostal ligament syndrome. And you can see the affiliation here between the thoracolumbar fascia that we're going to go over here shortly. That's an important girdle, basically, for uniting the posterior back muscles with the anterior abdominal wall muscles. Nuchal ligament, a specialized ligament that we see in the neck, posterior neck, and it runs from C7, where the supraspinous ligament below has just ended, and runs on the tip tops of the spinous processes all the way up to the occiput and ends on your inion. And if you feel the inion just below the inion in the midline and you rub back and forth, you can feel the nuchal ligament as it runs here. Who's ever heard the nursery rhyme that uses the term nuchal ligament? You all learned a nursery rhyme when you were a kid that used nuchal ligament. It didn't call it nuchal ligament. It called it the Old English form of nuchal ligament, which is paddywhack, right? Everyone's heard of paddywhack. Knick-knack, paddywhack. So paddywhack is just bovine nuchal ligament that would be dried and thrown to the dogs to gnaw on. So you never knew you were learning anatomy as a toddler, right? So nuchal ligament, important in craniocervical stability. Now, the anterior longitudinal ligament, as you start to ascend up to the skull base between C1 in the occiput and C2 and C1, thickens, right, and changes its name to an anterior atlantoaxial membrane and anterior atlanto-occipital membrane. So thicker, and it's based on the idea that you need to further stabilize those bones as you're getting into this more mobile craniocervical region. Same with the ligamentum flavum. So ligamentum flavum, as it runs between C1 and the occiput, changes its name to the posterior atlanto-occipital membrane, which is a mouthful. Now, so if we're doing a posterior view, so this, let me orient you. This is the skull base. This is C1's posterior arch that's been disarticulated. C2 posterior arch, or excuse me, posterior elements that have been disarticulated. This is the ascent of the posterior longitudinal ligament. And posterior longitudinal ligament obviously helps to inhibit hyperflexion of the neck, right? That makes sense based on its position. That ligament, as it crosses over C3, C2, changes its name, right? So this is the continuation here that's been folded up to something called the tectorial membrane. It becomes thicker, wider, and has a direct attachment onto the skull base, which is here. That tectorial membrane, once you pull it down, you see this elaborate array of ligamentous structures that are specialized ligaments just to hold C1 and C2 to the occiput and keep everybody from moving and interfering with the spinal cord. The first structure you'll see, it looks somewhat like a cross. hence the name. This is called the cruciate ligament, just like you see in the knee. And the cruciate has this much stronger horizontal part, which is called the transverse ligament. That transverse ligament is small and stout, but can stand forces of up to like 600 newtons. So it's an extremely strong structure, which tells you that the body is very concerned about the odontoid moving posteriorly. It doesn't want that to happen. So it puts this strong ligament here. It also puts in some accessory ligaments that we'll not go into, little vestigial ligaments. It also has this ligament that attaches kind of like a wing shape, so it's called the alar ligaments, from the sides of the odontoid up to the cranial base, just medial to the occipital condyles. And those alar ligaments help to restrict, they used to be called check ligaments. They help to restrict rotation of the head so that you, if you see an owl and dissect an owl doesn't have alar ligaments, right? There's no restriction of its rotation. We're coming, yeah. Sounds like a Harry Potter character, you know, the ligament that's yet to be named. So this is C1, C2, and there's a strong transverse ligament here, and odontoid with a little synovial joint between bone and ligament, and then joint between bone and anterior arch here. So that allows for better rotation. Alar ligaments that you can see. So there's a new ligament, I'll not fully divulge it, that we found that's on the anterior part of the head, and it's very difficult to get to, and we're going to give it a name here shortly. So I'm thinking Costantino ligament. How does that sound? Yeah, I love it. So this is a sagittal section through the cranial cervical junction. That's the base of the skull. This is your odontoid. There's the anterior arch of C1. Here's our anterior atlanto-occipital membrane. We have our dura mater, tectorial membrane, dura mater, our transverse ligament, intervertebral disc, all there to help keep that as a stable joint. All right, let's move down south and look at the specialized ligaments that help fuse L4 and L5 to the ilium, and that's called the iliolumbar ligament. The iliolumbar ligament, if you look at it in fetal tissue, is almost all muscle. So it degenerates over time, and by the time you're an adult, becomes this ligamentous structure. It has 5 parts. We'll not go over them all, but it has a vertical part that comes down to the ilium from L5, an anterior part from 5 to the ilium. It has a little portion from L4 that runs over to the ilium, and a couple of others on the back. So this iliolumbar ligament holds L4 and L5, which have the propensity to be hypermobile, and we don't want hypermobility of those two vertebrae. So nature has designed this beautiful array of tethering bands that help hold those structures intact. You also see the relationship between the quadratus lumborum, a muscle of the posterior abdominal wall, and that muscle has an intimate relationship with the iliolumbar ligament and runs between the 12th rib and the iliac crest. So the sacrum, I told you, is important in distributing weight that's coming down through the lumbar vertebrae, and then it takes it out through the ala, right? It doesn't take it down through the sacrum. That's why the sacrum gets smaller, as I told you before. Out through the ala, down through the ischium, and then out through the femur, right? It's a beautiful design to help accommodate this upright posture. You'll see if you put weight onto the lumbosacral junction, when you do that, it starts to rock the sacrum posteriorly and pull the L5 forward, right? This little reverse clock here. And ligaments that help restrict that, sacrospinous, sacrotuberous ligament. Here we see the interosseous ligament of the sacrum that helps hold the SI joint together. So a great design that works for most people. We showed this before. This is sacrospinous and sacrotuberous ligaments. We see them here in the pelvis. And by putting these things in the pelvis, between the sacrum and the pelvis, we create these greater and lesser sciatic foramina, right? So everything that needs to leave the pelvis and go into the perineum or the gluteal region goes through the greater sciatic foramen. If you need, once you get into the gluteal region, you need to return to the perineum, you go through the lesser sciatic foramen. So one is kind of an exit, and one is egress back to the perineum. You'll see a lovely design of these posterior sacroiliac ligaments, sacrotuberous here, with attachment from the sacrum and ilium down to the ischial tuberosity, and then it usually has a little ledge that walks on out onto the ischial ramus, and that's referred to as the falciform ligament or the sickle-shaped ligament. And on that ligament is the pudendal nerve. So the falciform ligament helps to form the floor of the pudendal canal, or Alcock's canal as it's more commonly referred to. Okay, so back muscles. Yes, ma'am. Yep. It's a good question. From clinical presentations, you see, that the carpal ligaments, the interphalangeal ligaments are much more affected. They're probably all affected, but those are the ones that, comes to clinical attention first. Sometimes whiplash injuries, so that their neck ligaments are a little more lax. They may have the propensity to have more injury. So the back muscles can be pretty complicated, although in med school we always taught, the back first because the muscles are big. You can't destroy them so easily, so it's a good way to get your feet wet as a first-year student. The muscles, you can kind of keep them straight if you remember that all the muscles in the back didn't originate there. So many of them started in the front of the embryo, were innervated in the front of the embryo, and then they migrated to the back and drug their nerves with them. So you'll see, for example, a cranial nerve that innervates a back muscle. You'll see ventral rami, brachial plexus that innervates a back muscle. That's because those muscles began up front in the fetus. So if we look at this is a very simple way. There are multiple ways to separate the muscles. We can talk about superficial muscles, right? So trapezius, latissimus, levator scapular, rhomboid, serratus muscles. These are most superficial and more or less have moved from the front of the developing human to the back. We have native back muscles that started off on the back, never left, and are still there. And those are of three different varieties. We have the splenius muscle, erector spinae muscle, and the transversospinalis muscles. And then I just group this into other categories. So muscles that run between the spinous processes, interspinalis, muscles that run between the transverse processes, intertransversarium, suboccipital muscles that we'll get to that are unique in themselves, and then little muscles that run from transverse process out to a rib, or the so-called levator costorum muscles. When we look at these, we can also separate the transversospinalis muscles. These muscles run from a transverse process to a spine, so they have a out to inside trajectory, and those muscles include the semispinalis muscles, right, to keep that name straight, the multifidus muscles, and the rotatories muscles. The erector spinae muscle has three parts, and these parts can get a little sticky, but you have a medial spinalis, a little more lateral longissimus, and most lateral iliocostalis, okay? So those three muscles are in a plane that's superficial to the transversospinalis muscles, more or less. And then splenius, we just have two muscles, so its own little category. This is the way you'll see in the beginning with a trapezius muscle. Here, this nice rhomboid-shaped muscle that runs from all the way up near the inion, the cervical spine and adjacent nuchal ligament, out to the lateral third of the clavicle, the spine and acromion of the scapula, and then has this angulation inferiorly down to the spinous process of T12. Nice rhomboid shape. And the innervation of this, as we'll see, is through a cranial nerve, and it's the accessory nerve or your 11th cranial nerve. The latissimus, the other superficial muscle that we see, has a very extensive attachment along the spines all the way up to about T5, anterior to where the trapezius is, all the way down to the sacrum. It then has some attachment along the iliac crest, the ribs, sometimes a little attachment to the inferior angle of the scapula, and then it runs anteriorly to attach in the intertubercular groove between the greater and lesser tubercles of the humerus. Latissimus dorsi is innervated by a branch of the brachial plexus called the thoracodorsal nerve from C6, 5, 6, and 7. And that muscle we'll see as we move along and talk about it in more detail. So trapezius and latissimus in a schematic view. The latissimus dorsi, if we look at it, and this basically its name just means it's a big muscle on the back of the human, has an elaborate attachment. It doesn't have just direct tendons into the spinous processes and iliac crest. It uses this specialized fascia called the thoracolumbar fascia. So it basically merges and then uses that fascia for its attachment. And we'll talk about the thoracolumbar fascia in an upcoming image, but that fascia basically forms a girdle, a fascial girdle that helps keep the muscles around the spine where they're supposed to be. This is a dissection from the lab and shows you a more accurate depiction of the trapezius. Here's the latissimus dorsi. We don't have time to go into all the multiple functions, but trapezius can help rotate the scapula, it can elevate the scapula, it can retract the scapula, etc. Latissimus, the swimmer's muscle, it and the teres major do the same thing, which is adduction, internal rotation, and extension of the arm through that innervation of the thoracodorsal nerve. Here's the dissection from across the hall here, and I've pulled the trapezius up off of its attachment from the midline and from the spine of the scapula, and we see the innervation. This is the accessory nerve, which is the strangest nerve probably in the whole body. It comes off from the upper 5 segments of the spinal cord, ascends up through the foramen magnum, so it goes from spine to intracranium, joins with a little part that is coming off of the brainstem, and then together exits through the jugular foramen, and then leaves to go out and innervate the sternocleidomastoid and the trapezius. So a very circuitous route to get that muscle innervated. And you can see that it covers up some of the more other superficial muscles. This is the levator scapula to the superior angle of the scapula, and then the spine here, and with the supra and infraspinatus muscles. Here are the rhomboid muscles that it also covers up, rhomboid minor and major, which we'll see better pictures of. There's our thoracodorsal nerve. Now, this thickened fascia, thoracolumbar fascia, is best appreciated if you look at a cross-section through the lumbar region, and you really just see this in the lower thoracic and lumbar region, and it thins out as you go more cephalad. But if we say, here's our spinous process, here's our transverse process, our transversus abdominis muscle, one of our anterior lateral muscles, has a thickened aponeurosis that somewhere close to the midline splits, right? And one split heads this way and attaches to the spinous process, so that's the posterior lamina of the thoracolumbar fascia. One split goes to the TP, the transverse process, so that's the middle lamina of the thoracolumbar fascia, and then debatable, some people will include this as an anterior component or an anterior lamina of thoracolumbar fascia that also goes to the TP but more anteriorly. So a fascial girdle, and what that's constraining is the erector spinae muscle here and all of its groups, the multifidus muscle, and then here we see the quadratus lumborum muscle. What do you think this muscle would be that's a little around the corner? Psoas major, right? Psoas major. So transversus thoracis, and then we see our latissimus dorsi that I told you uses its tendon and uses that thoracolumbar fascia posterior lamina to make it back to the spinous process of that level. A little more schematic version, so multifidus, compartmentalized, or longissimus, iliocostalis. These latter two are part of your erector spinae muscle, quadratus lumborum. So if we peel up the trapezius, we see the deeper muscles, so levator scapula, that has attachment from C1, 2, 3, and 4, then runs down to the superior angle of the scapula. Our rhomboid minor, we see from C7 or T1 over to the medial or the vertebral edge of our scapula. And then just below that, the larger rhomboid major. These two muscles innervated like the levator scapula by the dorsal scapular nerve, which is a branch of the upper trunk of the brachial plexus. And those three muscles collectively, levator and the two rhomboids, will retract the scapulae and then elevate the scapulae. The muscle that we'll find just deep to the rhomboids and not, sorry, I'm pointing to the wrong one. Here's the rhomboid major and minor. The muscle that's deep to that is here, the serratus posterior superior, that attaches on ribs 2, 3, and 4, right? And is an accessory respiratory muscle. Latissimus, we've peeled the latissimus off here, and you also have a serratus posterior inferior that attaches to the lower 3 ribs. Again, an accessory respiratory muscle, and both of those 2 muscles are tiny, very thin, probably don't contribute very much to movement like the serratus anterior, which is a very powerful protractor of the scapula. When we remove that posterior portion of the thoracolumbar fascia, you're left with these 3 columns of muscle that run longitudinally, and these are the erector spinae muscle. So a lateral part, which is the iliocostalis, a more medial part, which is longissimus, and a tiny little part that hugs the spinous processes is the spinalis. So erector spinae help to extend the flex spine, maintain extension of the spine, but are also involved, interestingly, when you're starting to flex. So as you reach down to pick something up, those erector muscles are contracting segmentally in increments to keep you from falling forward, which is interesting. So a muscle that has dual functions, which muscles usually don't have. So here's another view of those erector muscles, erector spinae muscles, and to complicate things just a little bit more, the different muscles have 3 parts each. So one part will, for example, if we start off with the iliocostalis, it has a lumborum part, a thoracic part, and a cervical part. The longissimus doesn't have a lumborum part. It has a thoracis part, cervical part, and then a capitis part that I'll show you. And then the spinalis is said to have a thoracic, a cervical, and a capitis or skull base part. Now, saying that, even though those are the descriptions, the iliocostalis has parts that go to the thorax. So iliocostalis, lumborum, pars, thoracis, right? It's a mouthful. And iliocostalis, lumborum, pars, lumborum, right? So different little parts to each segment. And you can do the same for the lumbar part of the longissimus. Interestingly, these are our dorsal rami. And if you remember, probably the most important take-home message when you're talking about innervation of the back is that the dorsal rami, right, do only one of 3 things. They either innervate, not either, they innervate the skin of the back, they innervate the deep native muscles of the back, and they innervate the facet joints, right? So dorsal rami innervate those 3 things. You can see here that the dorsal rami, as they're coming up to the surface, they characteristically run up through between this plane, between the iliocostalis and the longissimus, and then we'll see what happens to them after that. So we remove the erector spinae muscle on both sides, and you can see the multifidus right here. And we start to see some of the semispinalis thoracis. This is semispinalis cervicis, and then this is the opened up semispinalis capitis. So if you remember back, I told you that the semispinalis muscle is one of your transversospinalis muscles. It runs from inferior laterally to superior medially and has a transverse process attachment and then a spinous process attachment, hence the name. The difference between the parts of the transversospinalis muscles is that some of them jump different segments of bone. Okay, so of those 3 parts, we have semispinalis, multifidus, and rotatories. The semispinalis, as you can see, it's a very long muscle, skips between its attachment 5 to 7 segments. So it runs 5 to 7 segments. Multifidus looks just like a semispinalis, but it skips just 3 to 5 segments. And then rotatories skips 1 max. Okay, so it's a difference in extent, but having similar attachments. So we're looking now at some of the transversospinalis muscles, and then up at the very top, we see our suboccipital muscles that I'll show you a better picture of. Here, as we've removed the transversospinalis on this side, you see some of the inner transversarium, right, medialis and lateralis, and those lateralis fibers will blend with the quadratus lumborum as they move out laterally. This shows it a little more nicely. So this is the 12th rib, our lumbar vertebrae, supraspinous ligaments that connect the tips of the spinous processes. We see the intertransversarium of the lumbar region, both medial and lateralis, and it's this lateralis blending with our quadratus lumborum. Here's our multifidus, right, jumping 3 to 5 segments. Here's our erector spinae muscle. On this side, we see the dorsal rami as they're exiting below their corresponding vertebra and heading up to the surface to innervate these native back muscles, the facet joint and the skin of the back. So if we look more cranially, we've opened up some of the muscles. So this is your splenius capitis. Remember, that's that third category. So the splenius muscle has a capitis and a cervicis. One attaches, the latter name implies where it attaches. So splenius capitis attaches onto the occiput, and the splenius cervicis onto the cervical vertebrae. The splenius muscles are native back muscles, so they get a dorsal rami innervation. So we've moved over our semispinalis muscle, and this is specifically the semispinalis capitis because it's attaching on to the occiput. We see some interspinalis muscles that run between the spinous processes. This is the supraspinous ligament. Here's our erector spinae muscle. And then here we see the muscles that form this little triangle called the suboccipital triangle muscles. Here's a better view. So this is our C1 posterior arch, C2 posterior arch, skull, right? And this is the mastoid process. And we've cut here the semispinalis capitis muscle. And now we see these little suboccipital triangle muscles. So a rectus capitis posterior major, rectus capitis posterior minor that is more medial, inferior capitis oblique, superior capitis oblique. And the importance of these little muscles, they're very small, is that they help form an important area to identify structures within the triangle. So the posterior arch of C1 lives there, and in the lab you'll be able to see the triangle and palpate inside and feel that arch. Most importantly, the vertebral artery. This is where you see this horizontal segment, or V3 of the vertebral arteries. It's come through the transverse process of C1. It then takes on a horizontal bend, pierces this posterior atlanto-occipital membrane, pierces the dura, and then becomes intracranial. Let's look at the spine from the front. So we've looked at a bunch of muscles that make up its posterior part. This is the anterior segment, and we see the upper cervical, all the cervical and the upper thoracic vertebrae. This is the skull base. And we have some specialized muscles. So in the front, we have the longus muscles. So longus colli muscles that span from about T3 up to C1. This is the anterior arch of C1. We have a longus capitis. We have a rectus capitis anterior and a rectus capitis lateralis that attach both of those C1 up to the occiput. So these muscles are important in flexing the spine. And these are also the muscles that the spine surgeons will basically get rid of when they're doing an anterior cervical discectomy with fusion in order to get down to the underlying disc and bone. This is a nice cross-section, like I showed you the cross-section of the lumbar spine before, that shows the superficial and deeper fascia of the neck. So this is the vertebral body of the cervical region, and these are the so-called prevertebral muscles, right? The longus muscles that we just talked about. The scalene muscles are in that. We see the spinal canal with the spinal cord. Here's the spinous process. And then a lot of thick muscles here that are on the back. So very few muscles on the anterior part of the neck, because the anterior part of the neck is the visceral part of the neck. So that's where we have our carotid artery, our internal jugular vein, trachea, esophagus, etc. So you don't want a lot of muscles there that would compress those important structures. Posteriorly, however, especially with our head being able to extend as powerfully it does, you need lots of various muscles. So we went through some of those, and you can see the fascial compartments between them. So they're loculated so that there's not muscle rubbing on muscle. And these different fasciae that are here are referred to as the deep fascia of the neck. A little blurry, but here's a good view of the rotatories muscles. The brevis, and I saw these in the lab this morning, are very small and short, and basically go from a vertebra below to a vertebra above. whereas the longest will skip a vertebra, right? So it'll go and cross an entire vertebra. Very small, the deepest layer right on the bone. This is a posterior view in the lumbar region, so a nice intertransversarium lateralis, intertransversarium medialis, interspinalis. All these little segmental muscles that are important not only in movement, restricting movement, but also in proprioception. This is a beautiful view of the nuchal ligament. So remember our supraspinous ligament here, and we have the nuchal up to the inion. I showed you this earlier. And in the cervical region, you'll see that the intertransversarium muscles are reversed, so that in the lumbar region, you have a medial and lateral intertransversarium, whereas in the neck, you have an anterior and posterior intertransversarium. And then again, our interspinalis muscles that run here. So all these little tiny muscles helping to maintain the function of the neck. Posterior abdominal wall muscles, right, surround the lumbar spine and the thoracolumbar junction. And some of those muscles we've already mentioned. Here's the quadratus lumborum. So this is L1 to L5 sacral promontory. Quadratus lumborum from the 12th rib to the iliac crest. This is our transversus abdominis that's coming behind that to help form our thoracolumbar fascia. We have our psoas major here, psoas minor, which you don't always see, and then the diaphragm that's up above with attachment onto the anterior spine and the ribs to the side. People usually mistakenly think of the diaphragm, which has an intimate relationship with the spine, as being a flat horizontal structure, but it's a domed structure, just like this picture implies. So this is the costal margin where it has attachment back of the sternocostal junction, and it rises up into the thorax and forms the boundary between thoracic cavity and abdominal cavity, but it comes all the way up to the 8th thoracic vertebra. That's the level that the inferior vena cava will pierce the diaphragm. The esophagus pierces at about T10, and then the aorta runs behind and out the diaphragm at T12. And those vessels and esophagus have an intimate contact with the anterior part of the vertebral column. Big osteophytes in the cervical spine in the front can interfere with swallowing, for example, by compressing on the esophagus. All right, let's look at some general concepts about the nerves and how they look. I told you in the very beginning that the vertebral canal is designed so that it can accommodate the spinal cord. There's some meninges that surround the spinal cord, and there's CSF, cerebrospinal fluid, some fat, veins, but primarily it's cord. And you can remember that the cervical cord is a little larger in diameter, so it has a larger spinal canal. The thoracic cord is thinner, so it has a smaller canal, and then lumbosacral region has a little enlargement, actually, as it's referred to, so it has a larger canal. I also told you early on that the vertebral column grows faster than the spinal cord, so that originally the tip of your spinal cord, which is called the conus medullaris, is down here in the sacrum, right? And then as you grow, this cord, quote unquote, ascends inside the vertebral column, so that now that the little nerve roots that did come off at the segmental levels, like this, almost at a right angle or perpendicular, now in order to leave their appropriate intervertebral foramen have to descend and go out much more caudally. So that's a group of dorsal and ventral rootlets, and we'll talk about what that means. And collectively, someone thought they looked like a horse's tail, so it's called the cauda equina. So if you do a lumbar puncture that's below where the conus ends, usually at L1 or L2 interspace, you're not in danger of getting the spinal cord. You could ding one of the rootlets, but that would be as much as you would do. So we also said that the cervical spinal cord gives off 8 cervical nerves, but there are only 7 cervical vertebrae, and then everyone else is aligned. So there are 12 thoracic vertebrae and 12 thoracic nerves. There's 5 lumbar vertebrae, 5 sacral vertebrae, and there's therefore 5 lumbar nerves and 5 sacral nerves, 1 coccygeal nerve. This is kind of the distribution of where the conus ends. I said it always ends at L1, L2, but man is a variable structure, so you can see it end as low down as L3. This is an older study of over 800 conuses, and they looked at. But you can see that L1 and the L1-2 disc is where most people's conus will end. If you open up the dura, this is the outer layer of the meninges that surrounds the spinal cord. It's basically coating the inside of the vertebral canal, just like that. There's the conus, and we see when we open up the dura, here are rootlets, right? Dorsal and ventral rootlets. And in the upper part of the spine, down to about T12, those rootlets are segregated so that the dorsal rootlets are separated from the ventral rootlets by these little extensions of pia mater, which is another layer of the meninges, called the denticulate ligaments, because they look like little teeth. This is a good example that shows you that growth of the vertebral column versus the spine and how we develop this cauda equina. Here's the dural sac that ends at S2, as I told you before, so that you can pinpoint that area through a caudal anesthesia. If we take off the posterior elements, so everything I didn't show you earlier, but the vertebral body is connected to all the bone in the back by these stout pillars of bone called the pedicles. If we cut through the pedicles, right, we see an interesting relationship. So this is the dura mater that contains the spinal cord and the spinal nerves. And then a little extension of that dura mater is the dural sheath around the nerve. There's a dorsal root ganglion, which houses some of our pseudounipolar ganglion cells for sensory sensation. And then just on the outside of that intervertebral foramen, we see a split into a ventral ramus and a dorsal ramus. So that happens here in the intervertebral foramen. And you also remember that the pedicle, right, so this pedicle is the same number as this spinal nerve. One issue, though, is that when the intervertebral disc herniates, usually in that posterior lateral direction, it doesn't take out this nerve that's hiding or actually protected by the pedicle. It tends to herniate and affect one nerve lower, so that if you have a L4, L5 herniation, you're going to take out the 5 nerve, which is more in the way than the 4 nerve, which again is protected by the pedicle. This is a very diagrammatic picture that shows you how the nerves, the spinal nerves come off. So we have spinal cord with a dorsal and an anterior part. You can kind of say that if you drew a line through here, that the posterior half of the spinal cord has to do with sensory functions and the anterior half has to do with motor functions. That's very stylized, but we'll go with it for now. So that the rootlets that come off, these all occur inside the spinal dura. These dorsal rootlets are carrying just sensory information, more or less, whereas the ventral rootlets are carrying motor information, both somatic, right, and autonomic. They come together, and here's a dorsal root ganglion associated with the dorsal rootlet to form this very short piece called the spinal nerve. And that spinal nerve sits close to or within the intervertebral foramen, and then very quickly branches off into dorsal and ventral rootlets. In the lab, I'll show you a nice, clean dissection that shows this branching. The ventral rootlets are obviously larger. Dorsal rootlets, not rootlets, rami are smaller. And remember, we said that dorsal rami you can corner and say it's going to innervate the native back muscles, the facet joints, or the skin of the back, period. The ventral rami, excluding the thoracic region, are going to go out and intermingle with other adjacent nerves and form plexuses, right? Brachial plexus, cervical plexus, etc. Each spinal nerve, right, that comes out, especially right here, is going to have communication with the sympathetic trunk. So sympathetic fibers will come off and come on into this sympathetic trunk via these rami communicans. So ventral ramus continues on. You see it give off, this is important, a lateral branch that we'll see later, and then these anterior branches. Over here, you can see the relationship to the muscle, so that the little branches come off, and this is a little inaccurate because it's clear now that you don't just have a medial and a lateral branch of the dorsal rami. There's an intermediate branch that comes off probably more proximally, so we'll call this our intermediate branch. But this dorsal ramus is ascending between the muscles to come up, and then it branches into a medial and a lateral branch, right, just like that. And we see that it'll innervate these native back muscles. It's innervating the skin of the back here, and then not shown is a branch to the facet joints. So everything, as I told you before, that a spinal nerve goes to, it has to go to a patch of skin, right, a dermatome. It has to go to some muscle and muscle groups, which is a myotome. And then it also goes to some bone area, a sclerotome. And this is just showing that depiction. It also shows you how the rootlets are segregated, right? They're either sensory or motor, right? Dorsal versus ventral. And then as they come out to the spinal nerve, it's mixed. So actually, everything in these ventral and dorsal rami are mixed. They're motor and sensory. This is the communication between the spinal nerve, or its rami, and the sympathetic trunk that runs paraspinally from the skull base all the way down to the coccyx. And it's in this sympathetic trunk that in between T1 and L1 we'll have fibers that come out of the spinal cord that bring to it preganglionic fibers, autonomic fibers, and then those postganglionic fibers will then come back, some of them, and join the continuation of that spinal nerve, both as a dorsal ramus and a ventral ramus. Supply things like the sweat glands, the blood vessels, etc., and the muscles in the skin. This is a simplified version, but I think shows the notion well, that the sympathetic trunk right here, and then the communication, the cord would be here. So these are the posterior rootlets that have sensory information, ventral rootlets that have motor information, and then we connect the spinal nerve to the sympathetics via the white and gray ramus communicans, so that if we take motor fibers that are coming out of the cord that are autonomic or sympathetic, they enter into a white ramus and then go to the sympathetic ganglia, synapse, and then postganglionic fibers can then leave the sympathetic trunk and go to like the heart, the lungs, the intestines, or they can come back through a gray ramus and be distributed into that spinal nerve and take autonomic sympathetics out to the periphery. Okay, here's some of the surface branches of the dorsal rami. So when you see this, you know that all the nerves that are shown on the surface, these are going to skin because they've pierced all the muscle that's available. So there's no more muscle, they're going to skin. And we'll see that these are these dorsal rami posterior branches. And remember we said they're medial and lateral components. And interestingly, I think in my next slide I show that someone actually followed out each medial and each lateral branch. And in essence, if you kind of say mid-thoracic area right here, everything up here in the darker color is going to be skin innervated by medial branches of the dorsal rami. Everything down here is going to be skin innervated by the lateral branches of the dorsal rami, right? This is a more accurate depiction of the spinal cord inside the cervical canal. And we see the dura with the spinal cord, some arachnoid trabeculations. We see the dorsal and ventral rootlets, the spinal nerve and the DRG. We see the ventral ramus, which is very large. Dorsal ramus is very small. And then we see the little rami communicantes here. And this is all, the spinal nerve is sitting here in this nerve sulcus between the two little parts, the tubercles for the transverse process. There's an interesting nerve. So we've talked about the dorsal ramus, the ventral ramus. Here are the rami communicans. There's also a nerve called sinuvertebral nerve that comes off the ventral ramus. It has a sympathetic component and a somatic component, and then could make up his mind. So he goes back inside the intervertebral foramen and then runs into the posterior aspect of the annulus, anterior aspect of the dura, and innervates both that anterior dura of the spinal column, the posterior annulus, innervates the blood vessels that are in this area, and may contribute to some pain that's not relieved if you're just targeting the dorsal ramus for that facet innervation. So sinuvertebral nerve or recurrent nerve of Luschka. Here's a typical procedure that many of us will have done if we live long enough. So when we have degenerative changes in the neck, etc., one target is to knock out the nerves that are serving the facet joints, right? You want those to not feel pain anymore. So the clinician has to know where those little branches are. So here's our ventral ramus going out, probably in this case, to the brachial plexus. This going anteriorly to the sympathetic trunk. Here's a vertebral artery and veins. And then our dorsal ramus coming back, right, with branches that I'll show you in another slide. So a target zone for knocking out the facet pain. Now, in the cervical spine, the thing you have to worry about is that the vertebral artery, which you don't want to play around with, runs just in front of those spinal nerves. So any targets that are too far anterior or go through the nerve could puncture the blood vessel. And here you see the vertebral arteries. It's rising up through C6, 1, 2, 3, 4, 5, yeah, C6, 5, 4, 3, 2, 1. And usually the anterior tubercle of that C6 transverse process is enlarged, and it's called the carotid tubercle or Shoshenak's tubercle, and you can use it, hence the name carotid, to press the carotid onto to stop bleeding if that's an issue. Posteriorly, we see some of the specialized nerve. This is C1, C2, and we see our suboccipital triangle. Right? We said that the vertebral artery lives in that triangle, as you see here. We also see the dorsal root ganglion, and here we see some of the branches coming off that will run out to form plexuses. These are the dorsal rami, rami and ventral rami. The dorsal rami also will form some plexuses. These are called, in the neck in this area, the plexus of Cuvier. And we see that it unites some of these named branches. Most branches of the dorsal rami go unnamed. You may call them like T12 or L1. These, however, get special names. So the dorsal ramus of C2's medial branch comes up, innervates muscles as it's going through semispinalis, and its name is now, instead of the medial branch of the dorsal ramus of C2, we call it the greater occipital nerve. And that greater occipital nerve is very important because once it pierces semispinalis capitis, it's distributed all the way up to the vertex of your skull and the skin. So the majority of sensation on the back of the head is relayed through these dorsal rami. The third dorsal ramus is medial branch. This is called the third occipital nerve that runs up near the midline through the nuchal ligament and ends here in the skin around the inion. Small little suboccipital nerve that generally doesn't have a cutaneous innervation from C1's dorsal ramus that I mentioned to you before. See if there's anything here. The C2 spinal ganglion, as we see, has an interesting relationship just below the posterior arch of C1 and then the superior lateral aspect of the axis. And it's been shown that that ganglion can be pinched with hyperextension that's acute. So injuries with a hyperextension component can pinch the dorsal root ganglia and can actually result in the occipital neuralgia that some people will complain with. The greater occipital nerve is easily found, and we show you in the lab that if you find your inion, right, so palpate your inion, and then 3 centimeters inferior lateral, right, and if you push 3 centimeters inferior lateral, you should feel a little bit of tingling or like electricity going up the back of your head. That's the greater occipital nerve, and it runs just medial to, and sometimes you can feel up on the scalp the pulse in your occipital artery. So when the clinician wants to see if you actually have occipital neuralgia or also treat it, they'll inject at that spot, but they have to make sure to aspirate in the syringe so that they're not injecting inside the occipital artery that's just next door. This is after we've done laminectomies of the upper cervical spine, and we see the relationship of the dorsal root ganglion. We see the ventral and the dorsal rami. The ventral rami of these spinal nerves, when we have a vertebral artery, courses along the lateral aspect of the vertebral artery. We see the dorsal rootlets that are contributing to that. Here's the little plexus between the dorsal rami that I mentioned earlier. Now in the thorax, when we start to see the dorsal rami come out, we see, I told you the landmark is to find your superior costotransverse ligament, right? That's the transverse process of a thoracic vertebra. There's a rib, and we see that dorsal ramus coming out. As it comes out through here, it'll swing off a medial branch that innervates the multifidus muscles primarily, and also innervates the facet joints in this area. it's a little blurry, but let's go to this. So this is a nice schematic that shows you the dorsal ramus here. Here's the larger ventral ramus. This is in the lumbar region. Here's the annulus. Here's our dorsal ramus moving and giving off a medial branch. There's a lateral branch and then an intermediate branch that some people might interpret as a branch off of the lateral branch. So we'll show that. But it's this medial branch that's going over the little hump here to innervate the facet joint, and it's already innervated the native back muscle. The lateral branch will continue on and split. And remember, we said in the lumbar region that the lateral branches are responsible for going all the way up to the skin and innervating it. So this would have a patch of skin associated with it, and at the same time would also innervate the erector spinae muscles as it's climbing up to the surface. A little more specific, so this is the ventral ramus of L1. These are the intervertebral foramina, and we see the ventral ramus colored in red, the spinal nerve parent here in blue, and then I've had the artist show the branches of the dorsal rami. So here we see, for example, a medial branch, right, that comes back up to the facet joint, and there's normally an ascending and a descending branch from each of those medials that supply, so one segment will supply a facet above and a facet below. We then have those medials come back and innervate the interspinous region, but not skin. We then have an intermediate branch, the IB here, that runs out and in the lumbar region will terminate in the longissimus muscle. And then the lateral branch, this LB, will come out, innervate the iliocostalis lumborum muscles, and then remember we just said will terminate in the skin, unlike its counterparts in the neck. One difference is that the L5 nerve has the ventral ramus, and then here's its posterior component that just has lateral and medial branches. There's not an intermediate branch at L5. And interestingly, the upper L1, 2, and 3 lateral branches are going to move over the iliac crest, and we term those the cluneal nerves. So they innervate, for example, the area around the SI joint posteriorly, and then the skin all the way sometimes down to the greater trochanter. Lots of nerves. So this shows you the intimate association between the sympathetic trunk running in a paraspinal location, its branches to the front of the vertebral column and the anterior longitudinal ligament. Here's a spinal nerve with the ventral dorsal ramus. And then we see these connections from L1 to T1 is where you see gray and white rami communicans, because that's the part of the spinal cord that has sympathetic preganglionic fibers. Below L1 and above T1, we only see gray rami communicans. And these branches we see connecting with the ventral rami over the sympathetic trunk. Collectively, they form this plexus that's on the lateral surface. It's called the lateral plexus for innervating part of the annulus, the bone itself, with autonomic fibers and the blood vessels, et cetera, that live there. This is a nice microscopic study that showed the plexus that lives here on the posterior longitudinal ligament. So these are the pedicles that have been cut. So posterior longitudinal ligament with this array of structures, and these larger parent trunks, where do they come from, do you think? Something that left the intervertebral foramen and then decided to go back in? Sinuvertebral nerve. So this posterior component here is all from the sinuvertebral plexus. This anterior plexus that's on the front of the vertebra is formed by communications across the midline between the sympathetic trunk. So that's the anterior plexus. People often think the sympathetic trunk stays on its own side of the body and doesn't cross over, which is erroneous if you look at these images. This is a great looking picture of the posterior elements. There's been a wide laminectomy performed, and we see the dura mater, the arachnoid mater, and the pia mater that would be on top of the little rootlets themselves. And we see the formation of the DRG, the rami that are coming off. What ligament would this be? Iliolumbar ligament, iliolumbar. And then this is the superior facet of S1. Lots of veins, so I'll show you in an upcoming picture that each spinal nerve will have an artery and a vein that are running with it. Now in the sacrum, things are a little different because we don't have the same type of intervertebral foramen that we had with the upper vertebrae. So here, the rootlets, right? These are dorsal and ventral rootlets, or the cauda equina, will come forward, and intervertebral foramen is inside the bone, and then that will branch. Here's the dorsal root into an anterior ramus, and then here's the posterior ramus, right? And the posterior rami of S1, 2, and 3 form something called the middle cluneal nerves, and these are important in innervating the back of your SI joint. So irritation of those nerve root levels can give you referred pain to the SI joint and vice versa. We talked about the accessory nerve has a pretty circuitous route from the spinal cord back up inside the skull, then outside of the skull to innervate the sternocleidomastoid and the trapezius. Those two muscles can also get some innervation, the sternocleidomastoid from spinal level C2 and C3, and then the trapezius C3 and C4. And it's still a little debatable if those fibers are actually motor fibers or maybe proprioceptive fibers. A study we did showed that there are some somatic motor fibers there. Plexuses, so all those ventral rami we talked about, except for the thoracic region, will come together and mix up and move around and form these elaborate plexuses that medical students and any student of anatomy are driven crazy by. So this is just to be all-inclusive and give you a snapshot into the complexity of the cervical plexus as far as the spinal nerves. And this plexus is formed in the upper 4 parts of the cervical nerve, so C1 to C4, and does various things. To translate that for you, there are branches that go to the skin over the neck. So your skin of the neck, there's a little behind the ear, there's some up to the jaw, there's some down over the clavicle. Those sensory fibers are from the cervical plexus. Your phrenic nerve that makes your diaphragm contract, part of it's from the cervical plexus. You have branches that go to the prevertebral muscles, scalenes, longus muscles, etc. So lots of important things here that you need. One interesting combination is that from the cervical plexus, there's a loop of nerve, and the body doesn't usually make nerves that look like a loop, and the loop is referred to as an ansa cervicalis, and this ansa cervicalis only supplies the muscles that are below your hyoid bone, that are the infrahyoid muscles that help depress the hyoid bone. So an interesting combination. This is if you removed all the cervical viscera, right? So the trachea and esophagus are removed or cut, and we see the prevertebral muscles, right? The longus capitis, longus coli, scalene muscles. This is scalene anterior. And the interesting thing is that the brachial plexus, its ventral rami is formed by C5 to T1, and those C5 to T1 fibers leave in between the anterior and the middle scalene. So they're sandwiched there. So someone with scalene syndrome or anterior scalene syndrome, scalene minimus syndrome, whatever you want to call it, can have potential hypertrophy of the muscles, contraction, and squeeze those nerves. I know every time I sneeze that I contract those accessory respiratory muscles, the scalenes, and I get dysesthesias that go down into my arm. So there is an intimate relationship between the scalene and the brachial plexus. Above that, we see the cervical nerve. So C1 would be here, 2, 3, 4, and then there's 5. And it's this upper C1 to 4 that goes out to form the cervical plexus. C5 to T1, we just said, goes out to form the brachial plexus, and you can't forget that the sympathetic chain or trunk is communicating with each of those segments. And here above T1, those segments, those little branches are just gray rami communicans. Brachial plexus, if we ever go into an upper limb, we'll go into that in some more detail, but just to show you how elaborate the body has put itself together and weaves these branches into delicate things so that you can come and find, a single branch here from C5 and compress it. And by knowing these maps and where they go, you know that that's going to affect long thoracic nerve, axillary nerve, musculocutaneous nerve, and then you pick out the muscles that will be involved. So learning that just is reinforcing that these ventral rami have importance, and it's good to, especially if you're dealing with the limbs, know where everybody comes from and who they go to, both muscle, bone, and bone less so, but muscle and skin. This is a nice, it's based on a dissection of the complexity of these nerves. So you see as you get down into the lumbar region that these ventral rami get a little crazy and just intermingle with everyone and form this complex lumbosacral plexus. This is a simplified version, but just while we're in the area, lumbar vertebrae and the ventral rami of L1 to L4 forms your lumbar plexus. L4 and down to S2 will help form our sacral plexus. So these branches are ventral rami. The lumbar plexus, the largest branch is the femoral nerve that is here, and the femoral nerve running between the psoas major and the iliacus is the nerve that innervates most of your anterior thigh muscles, right, your quadriceps, etc. The largest branch of the largest branch of the sacral plexus is your sciatic nerve, right, which innervates almost the entire lower limb, less the anterior thigh, which is femoral nerve. Skip through those. This is an interesting picture, old picture that shows the anterior vertebral bodies are removed. It leaves in the sympathetic trunk and shows you the cauda equina with its branches. So this is T12. L1, 2, 3, 4, and then we start to get down to 5, and you can see 1 to 4 forming the lumbar plexus, which is really sandwiched and interdigitating in the psoas major muscle, and then below that running down to form the sacral plexus. All right, just a few blood vessels for seasoning. So this is vertebral artery. We've talked about it off and on, and this shows you nicely the vertebral artery is the first branch of the subclavian artery, which is here, and it rises up this V1 segment and enters the C6 transverse foramen that we talked about, a little triangle here between the longus colli and the anterior scaling muscle called the vertebral artery triangle. It then will run up through those transverse foramina and then come out C1 transverse foramen. It becomes horizontal here, so the transition from the V2 segment to the V3 segment, running in and becoming intracranial, and left and right vertebral arteries, we said, supply a third of the brain supply to the blood supply to the brain. So important structure that has no way of getting around being associated with the cervical spine and pathologies that are in this area. If we look at this is a posterior view on the left, so we're looking through the back muscles. We've done laminectomies. This is the vertebral body. So spine would be here, but it has been removed, and we see some of the intimate relationships in the thorax. This big system of veins that collect the intercostal vessels. Intercostal veins is called the azygous vein. We have tributaries into that azygous below, so very intimate relationship with the anterior vertebral column. The venous system in the body is shifted a little bit to the right of midline, so that's from this view appropriate. And then you see the aorta that's also giving off segmental vessels, right? In this area, intercostal vessels that shifted a little bit to the left, right? Just in front of the vertebral column. So bad anterior vertebral fractures with bone fragments can injure the aorta. From an anterior view in the thorax, we see the relationship right on top of the vertebral column of the trachea, esophagus, and aorta. That's from front to back. And then in the gutter here, at the where the head of the rib lies, we'll see the sympathetic trunk. And then we see the blood vessels in the intercostal space draining back midline toward these structures. This is a nice relationship of the neurovascular structures that kind of hug the circumference of the vertebrae. We see a vertebral body, so here's our anterior longitudinal ligament. This would be the aorta and the thorax. So we have these posterior intercostal arteries that come back, and these are destined to go to the back, right? So they'll supply the back muscles, the skin of the back, but as they're passing by, they can't help themselves. They go through the intervertebral foramen, and I'll show you in an upcoming slide, and also supply the vertebra itself, plus the spinal cord that's on the inside. Here are rootlets, right? Anterior rootlets, since we're looking from the front, and dorsal root ganglion. Here's the spinal nerve. We see our dorsal ramus, and then this is all ventral ramus, and in this case, it's an intercostal nerve. Veins also run in this area, and you've probably heard before the VAN, vein, artery, nerve, from top down as they run in the intercostal space. Sympathetic trunk running on the necks of the ribs, or the head of the ribs, and then we see the ramus communicans. Vena, a big vein, this is the azygos, and then also in an association with the anterior thoracic vertebra, and much less with the lumbar, is something called the thoracic duct, which collects 3/4 of the lymphatic return from your whole body. It runs here kind of sandwiched between the aorta and azygos in this picture. As we go down, the aorta, right, is going to split usually at about L4. Right, the vena cava will begin at about L5, so it's a little bit lower. And we see some branches that come off of the internal iliac in particular, and those internal, those branches, lateral sacral branches, go inside the anterior sacral foramina and supply the bone and the meninges and the nervous structures that are within them. So this is a snapshot. Those segmental vessels, so the segmental vessels in the neck would come from primarily the vertebral artery. There are also smaller vessels like deep cervical, ascending cervical that do that, but primarily vertebral. And in the chest, these segmental vessels come from the aorta, and we call them intercostal vessels in the chest. And then as we move down into the lumbosacral region, these same segmental vessels are called lumbar arteries. So these vessels come off and not only go to the back and the muscles and skin of that area, but also come back in and travel with the rootlets and supply the spinal cord itself, right? So these are coming in perpendicularly, right, up and down. You also have vessels that are running vertically on the spinal cord to supply it, and these vertical columns are called the anterior, which we see here, and then a posterior spinal artery. So you have this kind of setup where the segmental arteries are supplying the cord, but you also have a vertical contribution, and the anterior and posterior spinal arteries come off the vertebral artery. So another reason the vertebral artery is important. The bone of each vertebra has a lot of blood supply, and it depends on what segmental area that you're in, on which blood vessel is going to come to you, but you have periosteal branches. You have branches that go inside the bone itself. The intervertebral disc has very little blood supply, so you don't see a lot of vessels heading in that trajectory. These are little radicular branches that run with the rootlets. We also have branches to the individual parts, so transverse and spinous processes will get their own small branches. So a ring of arterial supply is found on each of these structures. You also have a specialized venous system of taking blood away from the spine and getting it back to the right side of the heart. And in the spine, that's simplified as calling this the vertebral venous plexus. A surgeon around the turn of the century named Batson described this in detail, so Batson's plexus. It was once thought that Batson's plexus, which runs from your pelvis all the way up and communicates with the veins of your skull, had no valves in it. So it was dependent on gravity. That has been proven wrong in some places, but it's still thought to be a major highway for transmitting, for example, tumor cells that arise in the pelvis, like a prostate tumor, and taking those cells retrogradely through this Batson's plexus and taking them, for example, to the brain, so that a prostate cancer can metastasize to the brain. There's also been some thought that maybe this collection of veins around the cord help to cool it and keep it at a nice temperature, doesn't get too hot or too cold. And you can separate these into an external plexus that's on the front of the vertebral body and on the back of the spinous processes, and then an internal plexus that's behind the body and behind the laminae here. So those three parts, anterior and posterior external and anterior and posterior internal vertebral plexuses. There's also an interesting little vein. This is a little cloudy, but this is called the basivertebral vein. And at each segment, each vertebral body, from the inside, you see a vein that drains through the vertebral body back into this vertebral venous plexus. So a basivertebral vein is a common finding and helps to drain the vertebral body from the inside out.